Hi, I'm Robert Byrne from the German Heart Center in Munich, reporting here from the ESC 2011 in Paris, France. And it's a real pleasure to be joined by Dr Manesh Patel from Duke, who's just presented the results from the CRISP-AMI trial. Welcome, Dr Patel.
Thanks for having me.
Yeah. Tell us a little bit of the background regarding the CRISP-AMI trial, which essentially looked at counterpulsation therapy in patients with anterior infarcts.
Yeah, as you know, patients with acute anterior ST elevation MI or myocardial infarction in general, despite improvements in our care, still have a significant mortality, in some series up to 10% at 6 months. And so we thought, based on the fact that counterpulsation improves your diastolic pressure and your coronary perfusion pressure and unloads the ventricle and helps with your EDP, initial animal studies had shown that infarct size was reduced when it was placed prior to reperfusion. So the hypothesis of the CRISP-AMI study was, can we show that in patients with anterior MI, myocardium at risk, placing the counterpulsation balloon before reperfusion reduces infarct size compared to standard of care?
Okay. And tell us, what endpoint did you choose for this assessment?
So we used cardiac MRI to look at infarct size, and that was done at day 3 to 5 in all patients. And the primary endpoint was sort of a co-primary endpoint, all patients that got a MRI for infarct size, and those with a proximal LAD occlusion to zero flow. We also followed all the patients at 6 months for clinical events.
Okay. And in terms of balloon counterpulsation then, was it protocol mandated that the patients had to receive them at the start of the procedure, or could they also receive them afterwards?
So the goal was that these patients with fairly large amount of myocardium at risk, at least 4 millimeters across the precordium, anterior STs, but not in shock, a clinical indication for counterpulsation, were randomized to getting the device inserted before mechanical reperfusion of the coronary artery versus standard of care PCI. And that occurred in 337 patients in the trial, about 30 sites in 9 countries. And the time to treatment in the entire trial was 71 minutes from first medical contact to coronary device, 77 minutes with counterpulsation, 68 minutes with standard of care. So about 9 minutes to put the balloon pump in first, and then continued for at least 12 hours after.
Okay, interesting. And what did you find then with regard to the primary endpoint?
Yeah, the primary endpoint, which was infarct size as a percentage of the left ventricle, was fairly large in both groups. It was 42% of the ventricle in the counterpulsation group and 37.5% or so in the standard of care PCI group. This was not statistically significant. Including the patients with proximal LAD occlusion to zero flow, again, a little bit larger but similar infarct sizes in both groups.
Okay, so really high-risk patients with a lot of myocardium at risk. I think one of the things that struck me really was the size of the LV infarct that these patients had. It's something that we've come to expect, that patients perhaps with a 40% or more of infarct volume will tend to have cardiogenic shock, but interestingly these patients expressly didn't have cardiogenic shock. Do you have any reasons behind that, or can you tell us anything more in this area?
So they were at risk. You know, we were looking for the patients, what I'll say, are teetering on the edge. They come to medical attention with a lot of ST elevation. Their blood pressure median in the trial at time of randomization was 130 systolic with a heart rate of 80. So they weren't in shock, but as you've probably seen in the presentation, 15 of the patients in the standard of care group did cross over to receiving a counterpulsation device. So there is some early risk of developing cardiogenic shock in some of these patients. But as a routine strategy, it did not reduce infarct size.
Okay.
At 6 months, I should note that the clinical events were interesting in the sense that the all-cause death rate was 1.9% in the balloon pump arm and 5% in the standard of care PCI arm. This was not statistically significant, but there was a little bit of separation there.
Okay. So where does this data then take us? A very nicely conducted trial, and it seems to be a clear message with no evidence of difference in infarct size between the two groups. Should we refrain from using balloon counterpulsation therapy in patients with large anterior infarcts who are teetering on the brink of cardiogenic shock?
You know, I think we asked a question and we were able to answer it, and it leaves me with sort of 3 messages. The first is, routine strategy of prophylactic counterpulsation in patients with large anterior MI without cardiogenic shock doesn't reduce infarct size. The second is, though, we have to be vigilant because some of these patients are teetering and can develop cardiogenic shock, as in this trial where 8.5% crossed over to getting the counterpulsation. And thirdly, and I think the most importantly for our patients and for others, is that acute MI ST elevation studies can be done with rapid reperfusion, and so we should continue to see ways to improve these patients' outcome.
Okay. Well, thanks very much for joining us today, and congratulations on an excellent trial and for presenting the results. I understand we'll be able to read about these results simultaneously in a publication.
Yeah, I have the honor of presenting the publication and the results, and it will be in JAMA online hopefully soon.
Well, congratulations, and thanks very much for joining us today.
Thank you.